And when you do conduits, any tips and tricks to prevent peristomal hernias?
Yeah, oftentimes you're taught to put your two fingers there and stretch that thing open and try to make it as opening. And I challenge the residents. I say, show me one case where you have obstruction at the fascial level, and that's, you just never have that. The obstruction is always either at the stomal level or some other process. So don't put two fingers. Don't stretch it so much. All you need is enough of an opening for the conduit to get through. That's one. Two is, look, it's inevitable. At least 25, maybe up to 50% of patients develop some form of peristomal hernia. My partner at Ahmed Jalada just finished a randomized trial of a mesh, pre-placing a mesh versus not for prevention of hernias. That's 150 patients, and we await the results. We don't know what the results show. So maybe in the future, that might be something in our armamentarium to prevent these hernias. Having said that, most of them are actually completely asymptomatic. There's something we see on radiographically on CT scans I follow up, and the patient doesn't even know it or realize it. So rarely is it an actual issue where you need to fix it.
Yeah, I think just like you mentioned for the handling of urethra, this is going to be surgical technique. It's going to be, removing a disc of skin, not going crazy, not, mangling the fascia or the musculature as you bring it through, trying to leave some, I try to leave a little bit of mesentery all the way out to the, distalmost end of the conduit as well. Just the little things to really keep that whole apparatus, which is of course what the patient interfaces with daily, well.
The other thing is we do a Turnbull stoma as opposed to an end stoma. We've always done a Turnbull, which many are not familiar with. They haven't done it in their training, so they haven't seen it. But a Turnbull really preserves the mesentery to the stoma itself, and I think really decreases the chance of stomal stenosis. We essentially just don't see it. We see all the other complications, and we see peristomal hernias, but we don't see stomal stenosis because the well preserved mesentery to the stoma.
What about, as we kind of wind down here, cutaneous ureterostomies, ureterosigmoidostomies, do those have a role in your practice at all?
Ureter six, no. And I think unless you want to go back to the early 1900s, but cutaneous ureterostomies, I think, are under used and underappreciated. I think in the proper patient with already dilated ureter, it can be an option. And there are plenty of series out there that are in the number in the hundreds that have adequate follow up and they do fine. I still do worry about the stenosis, obviously, but I don't have a large experience. But of the ones that I had to do imperatively for either bladder cancer or other, have done quite well, surprisingly. And you can't have an obese patient. So I think there are a lot of limitations to patient selection, but it is underused, and we always think we have to do an ileal conduit, and not necessarily.